Like my kids running around.
Good morning, Nicole.
Good morning, Dr. Salu. Thank you for having me today.
Welcome. Well, we're in this program. We call it Oxygen Weekly. So we talk about health, we talk about building healthy communities, and of course, about COVID and COVID vaccine and the ramification of this pandemic, which affected everyone, whether you like it or not. Everyone now knows someone who either got infected with COVID or hospitalized with COVID or died with COVID. I mean, last week we reached this very grim milestone of having 500,000 people died in the United States because of the COVID. This is more than people died in the Second War, First World War, and Vietnam War combined. So, Nicole, you're a nurse at the Christ Advocate Medical Center, where we work together in the intensive care unit and the step down unit. Maybe you want to give more background about yourself to the people who are seeing this.
Yeah. So welcome those that are joining us live right now and listening after. So like Dr. Salu said, I've been a critical care advocate Christ now for 13 years, actually, 13 years total as a nurse. I worked at Payless Hospital too for a little bit in an outpatient surgical center. I'm a mom of soon to be 3 in May. And my background for the last 13 years has been critical care.
Well, a critical care nurse. So that means you work in the intensive care unit most of the time,
Yeah,
right?
intensive care unit, step down unit. Before we had step down units across the country, I worked on the telemetry unit, which was like a step down unit. So I've been around enough, but still have plenty to learn. But through the years of the changes and the direction of critical care and the types of patients that we've had evolving through the years with more complex medical issues.
So step down unit is a unit between the intensive care unit, which is the highest level of critically ill patients, and the regular floor. So patients are not sick enough to be in the intensive care unit, but they're not less sick to be in the regular floor, right? They still need to be monitored closely. Nurses to patients ratio is still low. Patients are on monitors and they can turn either way.
Correct. We're the nurses that are keeping an eye on them, watching them critically to decide what direction are they going to go. Are they going in the direction of intensive care, or are they going to pull through whatever disease process they're going through and make it to a regular floor? Through the years, it's honestly a position that I find to be one of the most important, because you really have to have strength in your critical thinking and being able to identify things as they're happening, because you don't have physicians there every day like you do in a lot of the ICUs across the country that are always at the bedside with you or easy to obtain. So it's definitely strengthened me as a nurse, I believe.
So the first maybe question that comes to mind, and for those who are watching, if you want to share this with people who you have in your network, please do so right now if you feel that this is interesting. So you've witnessed other outbreaks, other pandemics through your professional career. Myself, when I started training in Chicago, it was the peak of the AIDS pandemic. At that time, I was getting my training at the University of Illinois in Chicago, Westside VA. Every other patient I saw had PCP pneumonia. Many of them were very sick, young people. And then we had a wave of multi-drug resistant tuberculosis to AIDS, also HIV. Then I witnessed another outbreak, pandemic, actually, the pandemic of typhoon avian influenza. So what's the difference between this pandemic and the other pandemic? And I think there's some noise in the background.
Oh, and my background.
Yeah.
Can you hear me now? Okay.
Yeah.
Okay. The difference for me is, outbreaks before and pandemics, you'd hear on the news that you'd see slow populations come in, alarming, you'd keep an eye on it. After dealing with this pandemic, the COVID-19 pandemic, it's hard to even remember that any of those could be categorized into what a pandemic or an outbreak is. It's almost been washed out of my mind to a different category of the feeling. The patients that we've had in recent outbreaks and different smaller pandemics, we've been able to manage better physicians and nurses, we've had ideas of how to treat them, and we've seen better outcomes with the type of treatment that we provided to them. More of the same outcomes with the COVID-19 pandemic. We could have a patient that is the same age, same comorbidities or no comorbidities. We can give them the same type of treatment. And as a nurse, I can see two completely different outcomes, one very sad and one that I think the patient maybe got lucky. And it's hard to identify with this pandemic, this COVID-19 pandemic, what truly has been helping these patients compared to other outbreaks that we've had in the past that we were able to treat, and the patients have been able to move on to their family and loved ones.
So the scale was much bigger. We had at one point all of our beds full with patients with COVID-19 who are requiring a lot of oxygen, who are requiring non-invasive ventilation. These are the masks that you wear connected to ventilators, and many of them ended up being intubated. And I remember that at one stage we had 2 patients in each room because we could not accommodate 1 patient per room as we usually have. So the scale was much higher, very sick patients, and unfortunately we did not have much to do to help them. We did not have specific treatment. We were experimenting in the beginning because it wasn't clear what works and what doesn't work with these patients. And many times the tools that we had were very limited, right? We put the patient on oxygen, we give them Decadron, remdesivir, and convalescent plasma, and then we hope for the best. Some of them end up, improving after a few days, a few weeks, and some of them end up on the ventilator, and then we wait them, and they develop renal failure and multi-organ failure and infections, and many of them die. So that was different than other pandemic where you had tools to use the patient to kind of, that this patient will make it. Many times in these patients, we did not know which patient will make it. Many of them, if they're elderly, if they have comorbidities, as you've mentioned, obesity, hypertension, diabetes, COPD, cancer, they did not do well. So are COVID patients different than other critically ill patients? I mean, if you want to maybe reflect on what are the main differences between COVID patients and non-COVID patients?
Well, I'm starting to get my non-COVID patients back, which is nice because our numbers are going down a little bit, but it's more of a reality to know that with the COVID-19 patients, the difference is we're almost there praying with them that these treatments are going to help them, to wait and see what direction they are going to go. And when I say direction, I mean, are they going to survive or are they going to possibly pass away? So you have patients that you look at for the first few days, you give them the treatment, you keep your fingers crossed almost, and I pray that that they're going to go into the direction of being with their families. So it's been a lot this year. Like having these COVID patients that are non-COVID coming back, they come in with their, maybe heart attack or respiratory virus. We know, we have experience in that. We know how to treat it. We know what's going to work. They start to get better. They move on to the regular floor. They move on to home or rehab, and it's nice to see. But there's still so much unpredictability with the treatment with patients that are still coming in, even though our numbers are low with COVID-19. They could get to day 3 and really be in a very bad shape with their breathing, wind up intubated on a ventilator for, just like Dr. Slew said, possibly weeks, and that's after getting all the treatment options that are out there right now.
But in the nursing care of these patients, are they more demanding than other patients in terms of the nursing care?
They're more demanding because everyone is so scared. There's so much misinformation and different directions of information that people have gotten, that when they come to the hospital, along with not having their loved ones there next to them, there's a lot of unknown. So you can't necessarily say, we're going to give you this and everything's going to be okay. We're going to try to give you what's out there right now for what we know with COVID-19, but there's no guarantees with what's going to work. And the anxiety that increases with them, you're spending a lot of time in their room because they're scared, because they're having trouble breathing. And so it's a lot of time in the room, and being in the room for a long time, you're wearing a lot of equipment in those rooms. I've had days where I've been in there for an hour and a half with somebody, with Zoom iPads, and dripping sweat because it's a lot of stuff to wear. And all of us nurses are in these, spending a lot of time, extra time in these rooms because people are afraid.
What are you scared that you may get infected, especially in the beginning?
I was in the beginning, but not where I wouldn't provide care the same for my patients, because that's just not why I went into nursing. And I saw that with other nurses and doctors. You have to kind of get over that fear in order to take care of people when you're in a field like this. And just try to take the biggest safety precautions. We're making sure that you didn't just run into a room without wearing the appropriate protective equipment. So I did make sure that through this, with prayer and with wearing my PPE, that I would be able to hopefully be protected and to make it through this without getting COVID-19. I have been blessed that so far I've been okay. And I think that has a lot to do with using my PPE and probably prayer too.
You're exception to the rule, though. Many nurses and physicians got, and respiratory therapists got infected with COVID.
They did.
Despite of wearing
Some of that was scary to see, as you know. There was a lot of physicians. That was really sad. Some people that I know that got infected, I do think maybe they did things also that, you know, they ran into a room for just that 2 minutes and without something on all the way. And you don't, who's to say if that's what could have given it to them? But I did get lucky. I isolated myself too at home. Luckily, my husband's working from home too, so I think that helped with that. Now that we have the vaccine, it's gonna hopefully help us out with future infections.
So, I mean, when you clearly you were emotionally affected by the patients that you were seeing. I mean, we're humans, we're not machines, and we are affected by what we see. Although we always, try to find a boundary between our emotions and the critically ill patients and the emotions of the families of the patients and us, because we do that every day. But how did you deal with this kind of emotional price that you had to witness every day, psychological trauma of the patients, of their families, the fact that they are very lonely because families are not allowed to visit them. They projected their frustration and anxiety and anger sometimes on the medical team. They suffered in silence. So, how did you deal with that as a human being, as a nurse? What did you do to reduce the toll of psychological trauma on yourself?
Yeah. It was hard at first. You don't want to bring that stuff home to your family, and it's at such a high level.
You have young kids.
I have young kids, so that was a blessing. Actually, I was able to come home in those moments, and even if I came home to a screaming home, I felt so blessed. That helped me get through all of the negative feelings that I maybe had in this from the stress of the day with, having other families that are going through this difficult time and patients, and then having each other. I do think that as a healthcare provider, between the physicians and the nurses, we've all been working really well with communicating with each other on our feelings and our thoughts. And I think that has helped us get through this too a little bit better, with leaning on each other. Sadly, though, I don't think it's helped some. Some people have been so stressed with this that they couldn't handle it, that they've left the bedside of where these COVID patients are, because we don't get paid a crazy amount of money to be a bedside nurse. So there's only so much a lot of people could handle before they just said, I'm leaving. I can't do this anymore. So some people, just like everything, cope a little bit better with others. But what got us through it the most, I think, was each other.
Do you think that, I mean, people do different things like take breaks, they travel, they meditate, exercise, uh, all of these things, you know, listen to music. I mean, at one point I saw in our unit these live streaming videos of puppies,
Puppies, yeah.
and actually it was soothing. Do you think that that was helpful? What else the hospital could have provided?
Yeah. So the hospital provided for us groups we could meet with. That was through Advocate Aurora, so we can go on groups to talk and schedule one-on-one sessions with therapists if we needed. We found that things like putting puppy dogs on screens, music therapy in our patients' rooms via the computers, or music therapy outside. It helped us, and we do have a room right now that we made that has a massage chair in it, to kind of, if you're able to get away, which when we see someone having such a bad day, we kind of push them into that room to just take a 10-minute massage and just kind of relax and breathe and try to reset their mind.
Yeah, I think yes. I mean, all of this probably helpful, but I think we have to pay more attention to our mental health. And I think one of the things that we're not talking about that much is not only the impact of COVID on mortality and long-term physical effect of the pandemic, but also the long-term mental health effect, not only on the patients and their families, but also on the frontline healthcare worker like yourself. Um, so, how did critically ill patients with COVID deal with COVID pandemic? I mean, many of them, of course, were lonely for a long time. They have the interaction with the medical team. They had their meals. If they were able to eat, many of the times they were not able to eat because they were on very high flow oxygen or the mask. So even meals were not part of their daily routine. They have the TV if they're able to be aware of that. I mean, what else? What else these critically ill patients used to adapt to the pandemic when they were in the hospital very sick?
Besides not being able to eat, there we would have patients that would be proning, so they'd need to be laying on their bellies to help with the breathing for days upon weeks.
What's proning for people who do not know what proning is?
So proning is when we turn a patient, or if they're able to turn themselves onto their stomach, they need to lay flat as long as they can. It's to help open up the airways, to promote breathing, to help. We did find with a lot of these patients, when we proned them and turned them, that their oxygenation would improve. Some patients, it was only to a point where it worked for maybe 5 days, and then it wasn't working anymore. But in the time of proning, you can't really eat when your lungs are so critical that they're only tolerating yourself to be on your belly. It's very uncomfortable. It's hard to go to the bathroom. You're hungry, and like I said, though, us being there at the bedside, I think, is what helped them get through it. A lot of times, these families dealing with this didn't want to talk to their family. They didn't want to see them in the state that they were in, because I think they realized how bad it was. So they would ask not to do Zoom calls. They would maybe just talk on the phone, and a lot of times say that they're okay, which you could tell that they were not okay, but they just wanted them to know that they were hopefully going to be okay. And a lot of them were very scared with the pandemic, and hoping that someday the following that they were going to hear on the news or hear from us that there was going to be some magical drug that would help fix this whole problem that they were going through, because their options were limited.
Yeah. mean, I remember many patients, of course, that you enter their room and they're very scared, but they try to smile or they give you the thumbs up. Um, many times, because, and this is probably unique of this pandemic, that we have to interact with patients, especially in the beginning, from behind the glass wall, the glass door. So you see the patient, you see what they are doing. You don't have to do physical exam every time. This is a kind of very predictable illness. They're on oxygen, and then you look at them and you raise the thumb up, and they raise the thumb up. And sometimes they don't look at you, or they try to avoid eye contact because of their anxiety and they're depressed. Sometimes we have to give antidepressant to them. So it was very lonely disease compared to other diseases. This is not funny, but one time one of the patient told me that he feels like he's in a zoo. He's like in a cage and people are looking at him from the outside, because of this different interaction between patients who do not have infectious condition like COVID and COVID patients. So, how did the families of the patients deal with their loved one, especially without family visitation?
Families did not deal very well with it. We had in the beginning a lot of families that would lie saying that they didn't have any symptoms of the virus when we were still allowing some people come up, and then they did. And they would be angry on the phone, a lot of crying, any sort of reason to try to get to visit the family when the whole time you're just trying to protect the community from the virus spreading, as you just see more and more patients coming in and you're running out of rooms and everyone's doubled up and you feel like you're in a ping pong machine.
Yeah, yeah. So looks like the kids are there, Nicole. So I mean, that's this is something that, of course, is very unique about COVID. That the family situation. Usually in a patient who's a critically ill patient, who have a critically ill patient in the intensive care unit, the families are allowed to visit. They're allowed to talk to the patient. They come and pray. The priest will come also, or the imam or the rabbi will come and pray with the patient, and that will help many times. And because of the pandemic and the policies of many hospitals, were not allowed. Well, anything else you want to add, Nicole, in the last minute or so?
Um, no, I mean, besides just everyone keeping your guard up, our numbers are going down and that's a blessing, but we are still getting scattered patients that are coming through, and doesn't mean that they're doing any better than the ones that we've had months ago. It's just a smaller number. So there's still a lot for us to learn about the virus. So please, everyone, keep your guard up. If you're able to get the vaccine when you can, trust medicine. um, and I think that's about it, unless any other questions anyone has.
Did you get the vaccine yourself?
I did not. I'll be honest to say I did not yet. I've had some complications with my pregnancy, placenta previa, and I'm kind of holding off, just hoping that that resolves before I possibly put any more stress on my body. It's something that I think about every day to try to cope with. And if my placenta previa resolves, I do plan to get it. As soon as this baby comes out, I also do plan to get it right away.
Right. Okay. I mean, I got the vaccine, of course, and this is something that we recommend to everyone. And right now, there's acceleration of the vaccination here in Chicago and the rest of the U.S. So anyone who has access to the vaccine should get it. It's safe, it's effective, and it's only way to contain the virus, because we do not have specific treatment for the virus. And I want to stress on this. We do not have specific treatment. We have some treatment that may reduce complications and maybe the intensity of the disease and the stay in the hospital. And even some of them, like dexamethasone, can reduce mortality, but we do not have specific treatment. Like, for example, influenza, we have specific drugs. Bacterial pneumonia, we have specific drugs, but we don't have that for COVID. Well, thank you, Nicole. This is very
Thank you,
helpful.
Dr. Slew. Thank you, everyone. Have a good Saturday.
Take care.
You too. Bye.